P.
What's good?
How are you today?
Merry Christmas.
Merry
Happy
Christmas.
New Year soon.
How was your holiday?
Holiday was decent. Relaxing, uneventful. Finally got a chance to, relax for a minute. So it wasn't too bad.
Well, that's good.
What about yours?
Uneventful. It's not a big celebration in my family, so I just was with a couple of friends and just ate dinner and relaxed at home and got to be off work. Both jobs.
Same me. Well, I mean, certain people in my family they make a big deal out of it. For me, it's just like it's a celebration, just to kick back, chill, relax.
I like to see the kids' faces light up. That's about it.
Yeah, I'm about home, but I just give money and keep it moving. At this point, my kids are old enough now, so.
Oh yeah, my kids.
She already started with the fibroids. We ain't started talking about the fibroids yet. Mama, give me a minute. Let's warm into this thing.
Okay, well, that's good.
They finally got
questions.
stuff back. Yeah, let you see questions now. That's what's up.
Because we was worried about that.
I guess y'all don't. Yeah, they don't want to hear us talk about life and family. They want to get to the questions. Okay. So let's go ahead and get it kicked off and get it started.
All right. Well, if you've been to the Q&A before, welcome back. If this is your first time, I'm Cola Red Bell. We are joined by the robotic hoe, fibroid slayer, Mr. DocP himself. I'm a patient of his. I went through treatment and surgery to treat advanced fibroid disease. I shared my story on social media, and ever since, the response was very positive. A lot of people have questions. Sometimes people have questions that they like to submit anonymously. So we try to do a Q&A. So far, we've been doing it like once a month. So, like I said, we'll keep doing them as long as they're needed. So we got questions in the chat, and I got questions that are submitted as well. So we can start with the chat.
We will get to the 3 small fibroids in a minute. Let's get to the other questions first, but I promise you we'll talk about fibroids and fibroid surgery and removal and all that stuff. We'll get to that. Go ahead and start the questions that you have.
All right. So the first one I have today is, if you have a hysterectomy due to a thickened endometrium with hyperplasia, I hope I'm saying this right, what proactive measures can you still take to assess the risk of having ovarian cancer?
Excellent question. So let's break that down a little bit. So the endometrium is the lining of for people that don't know, I kind of break everything down. So I'm sorry if I'm being redundant for some, but other people really don't know. So I want to kind of break everything down. So when I talk about these questions, sorry if I'm talking over somebody's head, but or if I'm being too rudimentary, just like realize that everybody kind of needs something explained to them. Even for people that know is great, but the people that don't know, it's for them. But anyway, so you got your uterus, right? The endometrium is the lining of the uterus, right? So every month, that's what sheds. It's the endometrial lining. So it's the inside part of the uterus. It's a very thin lining, right? The importance of this lining is for pregnancy, right? So in a nutshell, what happens is this lining, estrogen is released by the ovaries. It builds up. An egg is released. Your ovary releases an egg. It's ready for fertilization. If fertilization happens, that egg is going to travel down. The fertilized egg is going to travel down the fallopian tube and plant into the endometrium. Progesterone then builds up, and it keeps that lining thick, and it keeps that lining stable. That's why you don't have periods after you get pregnant, right? If pregnancy doesn't happen, right, you have the egg, it'll disintegrate. The progesterone levels as well as the estrogen levels, they start to decline, and that lining breaks down, right? That's where you have your period. It'll repeat the next month and the next month after that for as long as you reproduce. Now, what happens is the most prevalent cancer of the uterus is endometrial cancer, right? And endometrial cancer is a cancer of that lining that I'm discussing. What she asked was a thing called endometrial hyperplasia, right? So hyperplasia means abnormal growth of cells. It's not a cancer, but it's an abnormal growth of cells. So women can have cancers or abnormal growth of cells of the endometrium. How do you know that? Well, one of the biggest indicator is very abnormal bleeding, right? So that's why it's important that if you're over 40 and you're having very irregular bleeding, 99% of the time it is nothing. It can be explained as physiologic. It's not a big issue. Less than 1% of the time, it is some issue with your endometrium. And if that is the case, you want to know that, right? So to just blow it off and just say, I just have heavy periods, they a problem, I don't need to go to the doctor, whatever. This is where the problem comes in, because you don't want to be in that 1% where there's an issue. So we do what's called an endometrial biopsy. So one of two things. One, if you are over 40 and having this issue, or two, if you're under 40 and you've had like birth control or you've had something to try to regulate your cycles and you still have irregular periods, you want to check to make sure that lining is not hyperplastic or even a cancer. If it is, well, let back up before I say that. So things that can increase that risk. Obesity is one major risk factor for having endometrial hyperplasia. And this is why when people come to me, and I'm harping on weight and harping on, staying fit, staying active, like keeping your weight down. It's not me being mean. It's me telling you that, being healthy doesn't just deal with just your heart and your lungs, but it also, for females, it also depends with the endometrium as well, because what a little known fact is that estrogen is created in fat cells too. So estrogen is created in ovaries, but if you have excess fat, it also produces estrogen. So if you produce an excess amount of estrogen, that lining in the uterus, the endometrium, can build and it could become abnormal. So the times that I've seen endometrial cancer happen, 90% of the time is usually somebody that's obese. And somebody that's obese that has had issues with bleeding, whether they bled too much or whether they haven't bled a lot at all, and that lining gets really thick and abnormal. In specifics to the question, as far as worrying about endometrial hyperplasia, moving on to a possible cancer. So there's all endometrial hyperplasia are not created the same, right? They have different levels now. So it's changed now to where we look at the endometrium in like stage 1, 2, 3, kind of like we look at the cervix. It used to be where we looked at endometrial hyperplasia with something called atypia. It has atypical cells or non-atypical cells, and that would determine your risk of developing an endometrial cancer. As far as that risk, it really kind of depends on the pathology of that risk for if you need a hysterectomy or if you need to just manage this conservatively, because the more abnormal that those endometrial cells are, the closer to a cancer, the more likelihood or the risk that you can have a cancer. So a hysterectomy may be warranted. But as far as ovarian cancer, there's not a true link with endometrial cancer and ovarian cancer. So be very specific as far as the two differences. So a person with endometrial cancer is not at maybe at a slightly higher risk of ovarian cancer. Don't quote me on that, because it may have changed, but it may be. But if it is increased, it's negligible increase. Endometrial cancer is endometrial cancer in of itself. But there's another link with colon cancer, with Lynch syndrome, and those types of things. But that's something we'll talk about at a later time. But as far as if you have abnormal periods, right, whether you greater than 40, less than 40, you definitely need to see your gynecologist, and just to see if there's a problem. Because yes, 99% of the time it's not a problem, but that 1% of the time it can be an endometrial cancer. And if it's an endometrial cancer, trust me, this is not something you want. It is not a very good cancer. It is extremely aggressive and is a very bad disease. Sorry, that was long-winded, but
no,
that was a deep.
That was a good question. So
that was a very good question.
And did I pronounce everything correctly?
Yes, you did.
Okay. All right. So next question. Y'all videos are the bomb. How did you lose 17 pounds if your fibroids were only 5 pounds and 6 ounces? Okay, so I mean, I'm not a doctor, but this is my guess, and then you tell me if I'm right. So, if my fibroids had stretched my uterus to the size of a 32-week pregnancy, my body could have thought I was pregnant for real. And if you, just like when you gain weight, your baby is what? 5 pounds, 6 pounds, 7 pounds, you know, you may gain 20 pounds to be pregnant. Your body gains extra weight to carry the baby. I didn't have to carry the fibroids anymore. So my body was like, you don't need the extra weight that we are storing to hold up my midsection or whatever. I don't know.
So, yeah, kind of, sort of. More importantly, well, you lost 5 pounds already. So from the 6 pounds. You lost 6 pounds. It was 6.
5 pounds, 6 ounces.
5 pounds, 6. Well, it was 6 pounds something.
Oh, well.
It was 6 pounds. It was like 6 pounds, 3 ounces, 6 pounds. It was 6 pounds something for sure.
Okay.
But so you lost like, let's say 6.5 pounds from the fibroids. Then fluid is another huge thing, right? So when you lose blood volume, so you had in your particular case, we lost a lot of blood, so I had to give you blood back. And so what will happen is like when you have a lot of blood that's inside the cells, water follows you. So when I put blood, when you get blood inside of you, the water flows into and follows the blood, and that causes you to pee, right? So when you pee, you're losing a lot of water weight. So I would imagine you probably lost another 5-6 pounds of just water weight alone. Then you weren't super hungry after, so you didn't eat a ton for a few days or whatever. So that made up for the other weight right there. So in addition, so from the size of the mass to water weight losing, or what we call diuresing, which is me peeing off a lot of excess water, and then just not having the appetite and eating as much afterwards. And then once you got, felt good and stuff, you start to get more active too. So that you start to burn more calories as well too. So adding all of those things up is an immediate 17 pound weight loss.
And for the record, I'm still down those 17 pounds. And if I act right during the week, it's 19 sometimes. But I've been on 2 girl trips this month, so I was drinking quite a bit. So I'm probably at the more 17, 16 right now.
So we got a whole new year. You don't have no periods. You don't have nothing restricting you, no pain. So we about to hit the gym. We about to get active.
Yeah, we working on it.
Let's go. Let's go.
I'm definitely eating right though. The gym is
you like the spokesperson for the people. You got to be a spokesperson for the people now.
You're right.
Everybody looking at you.
I accept that. All right, let me go to the next one. Sorry. I always forget my password.
So I'll talk about, somebody asked about like 3 fibroids or whatever, small fibroids. So I will continue to say, right? So 80% of Black women have fibroids. It's a fact. 80% of Black women have fibroids. 70% of all other women, non-Black, have fibroids. That means 7 out of every 10 women in the world have fibroids. Why am I not always in the operating room every moment of the day? Is because fibroids are not built the same, right? So if fibroids are causing you symptoms, pain, bleeding, pain with sex, discomfort, frequent urination, bloating or pain when you press on your belly, like it's a ton of different things. If they're causing you to have infertility, right? If they're causing you to have a problem, that's when they need to be addressed. If they are not causing you to have issues, you don't necessarily have to address them. Like I have women right now that have very large fibroids but live very productive lives, and they're not bothering them. When they come and see me and say, I need, consultation on my fibroids, people think I'm just really trying to just go and just perform surgery on people. If anybody's ever seen me, you will see first, I am not trying to operate on. If it's that's the first thing that I'm asking. What are your symptoms? Not if you have fibroids. What are your symptoms? If you're saying I don't have any symptoms, are you having issues with infertility? If all of those answers are no, it's something that we can watch and wait. Now, I do have some women that say, look, I'm not bleeding, I'm not having pain, but I've been working out like nobody's business, and I had this big bulge in my belly, and it's really, really bothering me. Or, I'm not bleeding or anything or whatever, but I'm having frequent urination. Like, I drink something and I pee or whatever, and they have a huge fibroid. Yes, they don't have horrible symptoms, but for them, that's impacting their quality of life. So they have the option of doing something about it if they want to do something about it. It really comes down to if the fibroids are impacting your quality of life or giving you, horrible symptoms. That's when you have to do something about it.
All right.
Or you have the option of doing something about it, rather.
So someone asked in the questions, what if you've had several myomectomies and you keep having recurring problems? And I might be paraphrasing it because it disappears from my end.
No, that's a fight that I'm trying to fight. Unfortunately, everybody not built the same. I actually just had a patient. Well, not a patient. Well, I had someone reach out to me, in which, like, a surgeon basically took her to the operating room, cut her open, and saw these huge fibroids, and basically said that there was nothing that she could do about it, and that she would have to have a hysterectomy, put it back in, closed her back up, and that was it. Now she's still walking around with these big fibroids and a big scar because the physician couldn't do anything about it. This is the type of stuff that I deal with. She's gonna come up here and I'm gonna fix it, but I deal with this. Same way you have, physicians that, will do surgeries and don't remove all of the fibroids, right? Or you could have, and what I'm speaking out on now is, and I'm a laparoscopic surgeon, I'm a minimally invasive surgeon, but when it comes to fibroids, I am not a big proponent any longer of laparoscopic myomectomies. And the reason that is because if you cannot feel it, that means a lot of the times you can't see it. And if you can't see it, then you can leave it. And if you leave it, it can return. So as good as I am laparoscopic surgeon-wise, I don't have x-ray vision. And when you do laparoscopic surgery, you can only get what you see. And if you leave it, it can come back. So I don't know particularly what type of surgery or what type of fibroid surgery that she had, but there's hysteroscopic myomectomies. Hysteroscopic myomectomy is when you put a camera inside of the uterus and you take a tool and you get the fibroid that's pushing into the uterus. What they don't tell you is that typically it's very rare for a fibroid to completely push in the uterus. You have half of it that'll push into the uterus and the other half of it will be in the muscle. So if I go in there and I just address the part that's in the uterus, there's still a significant part in the muscle that's not addressed, and that can grow, that can still push down into the uterus with time. It can still have problems. So not to say that if you completely remove all fibroids that they can't come back, but I see the problem that I see most of the time is that fibroids are not adequately addressed, and therefore they become problems in the future. So, if you had a particular issue or whatever, reach out to me and I'll look and see what your case is. But if you're having recurrent fibroids, the chances are it's just not being addressed adequately.
All right. What if you don't have heavy bleeding, but you have a lot of irregular bleeding and random spotting? Should that be a concern?
It can be. It can be. So very first thing you want to do is get an ultrasound, right? So a pelvic ultrasound will at least let you know if fibroids are a problem or if there's something else that's a problem. And then there are other labs that you want to get. You want to get a thyroid. So if you have hyperthyroid or hypothyroid, it can cause you to have abnormal periods. You want to look at, weight, lifestyle, diet, eating habits, stress level, medications. Like there are a ton of different things that can cause you to have irregular bleeding. But with all of that being said, if you get a full and adequate workup of your abnormal bleeding and it's still normal, then realize that abnormal periods do happen. Sometimes they just don't have a rhyme or reason. Sometimes they are physiologic, meaning that that's just your body and you just have abnormal bleeding. But you have to undergo a full workup to find out exactly what the problem is and to see what type of treatment options that are available for you. I have women that have horrible bleeding all their life, and nobody's really adequately worked them up to find out exactly why they're bleeding. They've thrown birth control pills at them. Birth control pills are not the answer for everything, right? You can't just say, oh, it's birth control pills are going to fix it, right? And people say, well, I'll do that. Well, no, I don't. Hormonal suppression is an option for abnormal bleeding, but it's not just birth control pills. And hormone suppression does not necessarily mean birth control. You can take hormone suppression for things other than birth control too.
All right. What is your opinion on Lystetta for heavy bleeding? There's a question in the comments in the video.
Yeah, so Lystetta is tranexamic. No, it's okay. No, you're just reading what you see. So Lystetta is tranexamic acid, and tranexamic acid is utilized during a multitude of different things, but it will help with bleeding. It doesn't work for everybody. I am a proponent of it if it works for you, but I'm not going to say that every patient that I prescribed it for that it's worked. It is an option for you. It is a non-hormonal option. You take it for the first 5 days of your cycle. You take it 3 times a day for those 5 days, and it is designed to decrease the bleeding. And it also should help with your cramping too. It does not work for everybody. If it works for you and you're looking for a non-hormonal option, then yes, it's a good option. However, realize again, I go back to, why are you bleeding? If there is a 10 centimeter fibroid that's pushing into the cavity of your uterus, you can drink Lystetta smoothies every day. It's not going to fix it. It doesn't matter. Like you have to realize the problem. So Lystetta is for people that have abnormal uterine bleeding that's not caused from some of the things that I mentioned before. It's just physiologic abnormal bleeding.
Okay. This is a direct message question. I want to remain anonymous. I am 28 years old and I don't believe I have ever had an orgasm. Can I discuss this with my gynecologist? They ask about pain during sex, but they never ask actually, do I enjoy sex? Is that an appropriate discussion to have at the doctor's office?
It is, but I will warn you that all gynecologists won't be able to answer it for you, unfortunately. But yes, it's definitely an appropriate question to ask your gynecologist. They should be able to help you with it. But 9 times out of 10, it comes down to clitoral stimulation, or it comes down to just really understanding the anatomy of your body. And if you don't understand the anatomy of your body, it's hard to teach someone else to. And a lot of times I have that, and I experience that when women, talk about this issue. It is, you don't communicate, right? And it's either A, you don't communicate because you feel nervous about communicating that with your spouse, or B, you don't communicate because you can't really please yourself. You've never had an orgasm. You don't really know what it takes to have an orgasm, and therefore you can't teach someone else to induce an orgasm for you. So it is definitely a conversation that needs to be had. You can start with your gynecologist. If your gynecologist can't answer that, then you need to either find another gynecologist or find sex therapists that can help. But your gynecologist, a good gynecologist, should be able to help direct you. And if they don't, they can direct you to a gynecologist that does.
All right. In the comments list, is early pubertal PCOS related to fibroid, middle-age fibroid development?
No, it is not. So I guess I'll explain that. So PCOS, polycystic ovarian syndrome, is a disorder in which it's predicated off of insulin resistance. meaning that your body is producing insulin, but you aren't uptaking enough insulin, and therefore you have free-flowing insulin in the body, and it causes all of the other hormones to be whacked. And I'm speaking very rudimentary, so anybody that's like in science or another gynecologist, like, don't be like, oh, well, you didn't say this. Like, I'm talking to people so that I'm not talking over their head, so they can kind of understand it better. But that's the nutshell of it. It's a misconception of it is that it's all obese people. PCOS, obesity, PCOS, obesity. And that's not true. I have patients with PCOS that are skinny, right? So it's not, it is true that obesity does increase your risk of PCOS. And it is true that a majority of my patients, a large number of patients with PCOS are obese. But I do have a significant amount of patients that are thin or normal weight that have PCOS. And the question specifically was asked prepubertal PCOS, which you don't see very often. I don't recall seeing that since like residency. Usually, PCOS is typically after puberty. It's usually if it's before puberty, it's usually something else. But early onset PCOS and a link to later onset fibroids, there is no link. You don't see out of the 80% of Black women that have, fibroids, there's no link to prepubertal PCOS. So I would say no to that question.
All right. What are some tips for healing after a hysterectomy and preventing vaginal prolapse?
So healing after a hysterectomy, number one. All right. So whether you have a hysterectomy with an open procedure, which I'm hoping that there are less and less open surgeries and more laparoscopic hysterectomies, regardless, either way, you have to realize that the uterus, the cervix are being cut out, right? The cervix is attached to the vagina. When you cut, it's basically like a cookie cutter around the vagina that releases the cervix and the uterus, and the cervix and the uterus are removed, whether through the belly or through the vagina. That hole in the vagina has to be closed, right? So if you want to heal, keep the stress off of that hole. That means absolutely nothing in the vagina. Please, God, don't ever do that if you had a hysterectomy. Don't have sex. Don't put stuff in your vagina. It is a surgical emergency. Like, that means it's the only thing that's separating your inside world from your outside world. You poke and you breach that hole, your inside world meets your outside world. You don't want to do that, right? So so that includes sex. No straining or heavy lifting, right, will help you. Eating healthy, right? That's something that we don't talk about enough, but eating healthy and drinking a lot of water, it helps with everything. It helps with healing. It helps how you live your life. And people they talk to me like, why am I having this discharge? Why does I smell like that or whatever? A lot of it is eating, right? You don't drink a lot of water, you dehydrated, you have abnormal discharge, right? It goes the same way with your healing process. What you eat and how you live your life, it will help you with healing, right? So when you are eating properly, drinking a lot of water, working out, having a vigorous blood flow. So when you work out, it helps you with your blood flow. It helps you with your circulation. Circulation is key. Not smoking, drinking, right? So smoking is another very harmful thing when it comes to healing, right? Anything that's harmful for the body, it's harmful for the healing process. So those are the biggest things. And straining, try not to strain when you lift. Try to take stool softener so you don't have to strain when you poop. Those are the things that you want to do to help heal after hysterectomy. What else did she say? She asked another question, but that was it.
No, that you got it.
Okay.
Well, this kind of leads into, this wasn't next, but I'm going to ask it next. What are the truths and myths about douching, and what should your vagina smell like?
Oh, she asked about prolapse too.
Oh, yeah, right? Sorry. Yeah.
So prolapse, all right, so a misconception. Hysterectomies do not increase your risk for vaginal prolapse. So vaginal prolapse is when you have a weakening of your vaginal floor muscles, and things start to push into your vagina. Whether that be if you have your uterus can push from the top of your vagina, or your bowel. So your rectum and your bowel can push from the back into the vagina, or your bladder can push from up top and down into the vagina. Hysterectomies do not increase your risk of that, right? There is a multifactorial thing, factors that will increase your risk of prolapse: smoking, age, genetics, chronic heavy lifting, chronic coughing, right? These are some of the things, or obesity, poor diet, like multiparity, meaning having, multitudes of vaginal deliveries. But most people get the misconception that it's just vaginal deliveries. I have women that have had 6, 7 vaginal deliveries are completely intact, and women that have had 1 or 2 that have horrible prolapse. It has a lot. It's not just how many deliveries you have. It's genetics. It's a lot of other different things into it. But as far as hysterectomy is concerned, that is not the factor that's going to lead to you having a prolapse, right? It's all of those other things that I said, but it's not if you had a hysterectomy or not. Next question. I'm sorry.
No, you're right, because I missed that. I'm sorry. What are the truths and myths about douching, and what should your vagina smell like?
Do not douche, period. Plain and simple. If I can't say it no clearer than that, do not put water, fluid, or any other thing in your vagina. It doesn't need your help, right? So the truth of the matter is this, and I've said this 1,000,000,000,000 times. I'm going to say it 1,000,000,001 times, right? As far as your vagina is concerned, there are bacterium called lactobacillus. Lactobacillus are the natural bacteria in your vagina. They produce acid. That's why your vagina is acidic. The normal environment of the vagina is acidic, right? When you go start putting stuff in there and you change the pH, you can change the pH to be more basic. When you do that, you increase the risk of the abnormal bacteria, or the bacteria that you don't want to take over from the good bacteria, right? Or when you wash, or you put water in there and you wash out some of that the normal bacterium that you need, you set up the infection for the abnormal bacteria to come in and take over. You don't want to do that. You never need to douche. You never need to put these things in your vagina. Realize this. Just like I said, the vagina is acidic. If you put things in there that are basic, it's going to cause an odor. That does not necessarily mean it's an infection. What those things consist of? Semen, okay? Semen is basic, right? If you allow him to ejaculate inside of you, realize it's basic. If you put a basic fluid in an acid, that's why it does not smell good for the next 2 or 3 days. It just is what it is. It'll go away. But just because you smell something after sex, realize it could be just because it's semen. It has to clear out. It does not necessarily mean an infection. What else is basic? Blood is also basic, right? So before you have your period, while you're having your period, and after you're having your period, you have a basic fluid that's in the vagina. It's going to cause an odor, all right? The rule of thumb is this. If you smell something and it doesn't smell right, if it goes away on its own, it's not an infection, period, right? It could just be the pH is off a little bit. It doesn't have to be an infection. If you have a vaginitis, yeast infection, if you have something that is causing your vagina to have a smell, it doesn't go away on its own. You need medication. You need antibiotics to fix it. So if it goes away on its own, that means it is not an infection. It just means there's something that is there that's causing the pH to be off. If you are douching, you set yourself up for an infection. Plain and simple. You keep doing, and douching doesn't just mean buying the kit and squirting it in there. Douching also means taking the rag, putting it on your finger, and rubbing it on the inside. That's the same goddamn thing. Or being in the tub and just like taking the water and just flinging it around in there. That is douching. I mean, it's not a summer's eve. It's not a regular douche, but it is a douche. It is. You're doing the exact same thing. Do not do that. You don't need to do that. And putting all of these new herbal boric acid, probiotic, yada, yada, yada. I tell y'all this all the time. I got 3.5 more years. I'm telling y'all, 3.5 years, I'm selling out. I'm selling out. I'm putting my name on something, and I'm just gonna take advantage of it because y'all crazy, right? If I can tell you that it works, you're going to do it, and you're going to spend money on it. So why do I try to do normal stuff, right? Trying to make money, and I can just say, hey, this does this, and y'all giving everybody your money that's lying to you. Elderberry douches. You probably buying that. Sea moss probiotic douches. You gonna buy that? Like, stop it. Like, you don't have to do this. But if you're going to do it, I'm going to capitalize eventually. Everybody else capitalized on it. If they can market it, they're going to sell it to you.
That's true.
You don't need it. Your body has been working decades, centuries, right? Before time. Your grandmama and them, your grandma's grandma and them. Like, they've been doing perfectly fine without all of this probiotic stuff that you see that they putting on there. I got people that are buying fibroid blaster pills. And y'all, like, if I get one more picture of y'all sending me talking about, that these work, what you think about these? No, it doesn't work. It doesn't work. But you're going to pay your money for it, and you're wasting your money. Please stop. Please stop. I know I'm being the ultra hater. I know people that are on there like, he don't know this, he don't know that, he ain't no woman. You gotta spend your money. You don't have to listen to me. Spend your money, all of it. People that want to like listen to logic and understand that anything that works or that has like some clinical value, it has to go through a clinical trial. What is a clinical trial? Clinical trial is this. I take 1,000 women that are, let's label them A, and I take another 1,000 women and I label them B. And whatever the hell I'm trying to sell, whether it's elderberry, sea moss, douche for the douche, whatever it is, right? The person that's giving it has absolutely no idea what they're giving, right? There's another person that's completely blind that knows everything that they're getting, but doesn't tell anybody. We give all of the 1,000 people in A, we give them whatever it is we think is, whatever we're trying to sell. And B, we give them placebo, sugar pill, water pill, whatever you want to give them. It's absolutely nothing. And then we measure them out. We measure out the black people, the white people, the obese people, the skinny people, the people with heart disease, the people on birth control, the people that have sex 8 times a day, the people that don't have sex at all, the virgins, the people that have a million babies and have everything that you can think of, you measure those out and you start to see the statistical differences. I promise you, with 99% of these things that they're trying to sell you, they have not done that. It's just somebody's like, oh shit, sea moss is booming. Let me just put this in a little capsule and just sell it to you and just tell you it's going to fix all your problems because you'll buy it. That's what's happening. And you all are just eating it up. So please don't send me another damn fibroid blaster pill or any of this other mess that y'all buying because the answer is no. For me, it's a hard no. But you can buy it, you can take it if you believe in it. God bless you. Go right ahead. All right, I'm done. Let me stop.
You're gonna have all types of testimonials.
I know.
On my YouTube, somebody
nobody talk about. I took that, and my whole life got that. Okay, all right, okay.
Somebody posted a comment on one of the YouTubes because I post this to YouTube that they swear by some doctor that I should go watch and they can help or whatever. So
okay.
Next question.
My sin is I keep it too real. You know what I mean? Like I'm that dude that just like they shouldn't have got a medical degree. That I just keep it 100. Like most doctors are not going to keep it real with you. I keep it 1,000. I'm like talking to your uncle, your cousin at dinner table. They should not. It's like they let the wrong person in the door, but people still don't want to listen. So it is what it is. Good.
Yeah, no, that makes perfect sense. All right. This one is in the chat, and sometimes it let me roll it down, and sometimes it don't. So I'm paraphrasing.
100%.
It sounds like
procedure to have two doctors is it procedure to have two doctors in the operation room for an open surgery? Yes, you can. You don't necessarily need to have two doctors. That's going to be more of a cost for you. Anytime you have two doctors in the room, you got to pay two doctors. But for an open fibroid surgery or whatever, you can have a doctor and a assistant. right? You don't necessarily, a surgical assistant, you don't necessarily need 2 doctors for most surgeries unless it's very difficult. So yeah, but the higher the level of skill of that other professional, the more your surgery is going to cost. Keep going. I'm just looking.
No, you're good. I'm trying to scroll and see them too. Can you get facial hair during menopause?
No. You can get facial. Well, Paul.
Okay, females getting facial hair. I'm sorry.
All right. So you can get facial hair at any time, right? So like you can have facial hair and it not really necessarily be a problem. If it is facial hair that is like thick, right? Like male type. Like there's true hirsutism. So hirsutism is the term that we use. So true hirsutism is this, right? It's like if you had this connection, like straight mustache, like this. It's not the 3 strands that come down on here, or like little fine baby hair mustache type stuff. That's not hirsutism. Hirsutism is thick, coarse, male type hair, and there's nothing in menopause that will make you have that. If you start to have that, then that will indicate that there's a higher level of testosterone or something else in your body that's causing you to have that. But menopause doesn't just cause you to have high levels of testosterone or causing you to have, hirsutism. You may have, hairs that grow, like just like older men have like hair growing out their ears and stuff or whatever. You just have hair growing out of abnormal places with menopause, but it doesn't cause you to have true hirsutism.
Okay. This one was in the comments, but again, I may be paraphrasing it because it won't let me see it. But they're basically asking, have you ever had to have an open hysterectomy because the vaginal canal was too small to pass through the larger fibroids?
No, I have not. I thought I was going to have one. It's crazy to ask that. I thought I was going to have my first patient about a month and a half ago, she had like a huge, she's a really, really, really small lady. It's like no babies, never doesn't really have sex. And I could not examine her in the office, very anxious. And when I did an exam on her, like literally 1 centimeter into her vagina, it was fibroid pushing into, like it was just all fibroid. Her vagina was completely fibroid, and her vagina was like the size of a quarter. So in my mind, I was like, damn, this might be the first case I've had where I think I might have to open her. But I didn't. Once I got in there, like I was able to kind of manipulate and I was able to get it out. So it's for me personally, there aren't many that I can see that I'm not saying that there's nobody out there that it would be impossible for me to do a laparoscopic hysterectomy on, but I've done a lot. And, Colorado, yours was extensive. It took me some time. I had to, me and your uterus and fibroids had to wrestle. We had to have a conversation. But even with that, I was still able to get it. And there's not many that's going to be worse than yours. Like I had one lady in California that I did the live with, like hers was slightly bigger, but between you two, it's not, you can't really get much bigger than that. And for that, as long as you can put the instruments into the belly, you should be able to do it. Now, some women have just waited way too long, and now it's like it's completely taken over their belly, and like you can't put instruments in there. So if you can't put instruments in there, that would be the point where yes, you'd have to do an open. But that's just, it's rare that you would find somebody. It's very rare that I would have somebody that happens to. I haven't seen it yet, but I'm sure they're out there. So the answer to that question would be 99.9% of people, no, I can do it laparoscopically, but there's one person out there that maybe I won't be able to. But I haven't met them yet.
Oh, that's why I say a robotic hole.
Yeah.
All right. This question I think is for me. How long did you have fibroids? So I had heavy bleeding starting in around 2015, but I didn't really address it with my primary care physician. I mean, I brought it up, but I didn't really harp on it. And then my annuals, the next following years, I skipped out on for personal reasons. And then when I did go back to the doctor in 2019, I brought it up again, and she scolded me for skipping all the visits in between as well. And she ordered an ultrasound. So the first time I actually saw them on the ultrasound was 2019. And then she referred me to a gynecologist because my primary is not a gynecologist, except now. Now I have a gynecologist too. And it wasn't that, well, she definitely said I had to have surgery, but I didn't necessarily want her to give me surgery, if that makes sense. Like, she didn't say anything bad. She did answer my questions, and she was a nice lady, but I just didn't have the energy like I'm coming back after I met with her. And then that's when I started doing research to find somebody that I would get, that I actually would feel comfortable having surgery. And it took a while because that was 2019. Then obviously COVID happened too. So I was putting it on back burner. But then it started impacting my sex life too, to be honest. And then it was like real serious.
Yeah.
So.
Yeah. It can't get serious. And so the young lady who actually, I wasn't shouting her out. So anybody think I was shouting her, I did not shout her out. But the young lady that reached out to me that had that issue with getting opened and then closed, she is in this thread, and and verified what I was saying. And for her, like, it angers me. Like, if anybody sees like some, if you could read between the lines, I can't, like, it's certain things I can't do. It's like being the police. It's like having your uncle as the police, but he can't tell you exactly what goes on behind the scenes, but tries to give you kind of like tools to tell you what's happening. So when y'all see me angry about like physicians not doing this or that, I've seen something. That means I've seen something. I can't tell you what I've seen, but I'm telling you, like, do your research on people, right? And she's a prime example. So, like, she literally went to somebody who gave her this big incision to take her, to perform a surgery and remove her fibroids, and couldn't do it. And therefore, she couldn't do it and just put her damn uterus back. And so now she has to deal with healing and still has to deal with these damn fibroids. So it's like, it's dude, you gotta do your research. Y'all have to do your research. Have to.
I agree 100%. Do you take referrals from Advocate?
Yes. I do. So I don't. The Advocate that I operate at is Advocate Illinois Masonic. So it's a whole long story of why I don't like. So my office is at Advocate South Sub, but I will tell you, I hate that hospital, and I do everything possible to bring people up out of that hospital. Right. So I don't operate there. I won't blast them too much, but I don't like the hospital, like, for multitudes of different reasons. But yes, I do operate on Advocate patients, but it's at Illinois Masonic and not South Sub.
Okay. Is shaving pubic hair recommended, or does the hair protect from something and we shouldn't remove it?
Hair does not protect from anything, right? So that's a great question. I've heard this question before. Realize that, yes, hair is a normal physiologic protection mechanism. We have hair in our nose, we have hair in our ears, we have, hair in our privates, yes, to keep bacteria and bad things out, but realize that's normal physiologic things, right? That happened with cave people, where they didn't have clothes, didn't have panties, didn't have any of these other things running around, right? So now that we have all of these things, we don't need hair, right? So if you want to get rid of your hair, get rid of it, right? It's not like you're a cave woman living in a cave and have to worry about bugs crawling in your vagina because you don't have panties and clothes on, right? You have panties, you have clothes. Those things protect you. You don't have to have hair. I will say this about shaving. Shaving will increase your risk of ingrown hairs or what have you. If you have problems with ingrown hairs and, razor bumps and those types of things, then it's better to wax or laser hair removal to alleviate those things.
What is the best way to handle hot flashes? Sorry.
So the very first, I will start this way. So this is what hot flashes are, right? So hot flashes are just a loss of regulation of your thermoregulatory centers, right? So estrogen allows women to have control of their thermoregulatory centers, which are just centers in your body that keeps your body temperature stable. Meaning that when you have, when it's super hot outside, it doesn't it'll cool you off to a point where it's room temperature. Or when it's super cold, it'll heat you up to where it's room temperature, right? When you have estrogen in your system, that's the normal thing that happens. When estrogen starts to decline, i.e. menopause, right, you lose control of those thermoregulatory centers. So when there are small changes in the climate or in the atmosphere, then your body doesn't sense those changes well. Like, for instance, if it's super cold, instead of bringing your body and heating it up to a normal temperature, a normal level, it'll overshoot and just heat you completely up because it doesn't have that regulation, right? So what I tell people is just understanding that. And a lot of times what happens is with the hot flashes, having them at nighttime. You having them at nighttime because you're sleeping with fans, you're sleeping with the window open. It's wintertime, you got fans and air conditioning on because you're preparing at nighttime for your body to automatically get hot. And so you're trying to make it colder. And what you're doing is you're automatically just throwing yourself off. So what's happening is your body, when you sleep, is sensing that it's very cold. And so it's heating you up. And that's why you're having these hot flashes. Whereas if you keep the room close to room temperature, and your body doesn't have to really kind of figure it out. So regulating things and not doing the extreme, like making rooms really, really cold or really, really hot, will help you regulate. So other things like, people will talk about the foods you eat, some herbs like St. John's wort, black cohosh, like those things. For some women, it works. I won't say that it doesn't work. For some women, it does work. And so with that being said, you can try some of those herbal supplements. When you talk about medications and those, all of the things that I just mentioned don't work. When it comes to medications, you don't want to just jump into hormone replacement therapy. You don't want to just start giving yourself estrogen, right? There's a risk to it. You only want to utilize that if you have to, right? If it comes down to that, your quality of life is impacted because of these hot flashes. You can't play with your kids because you have these horrible hot flashes. You can't sit through something, or you enjoy life because you always hot and you having these horrible hot flashes. That's quality of life issues. But the next step would be SSRIs or antidepressants, in particular paroxetine or Paxil. People are like, I ain't crazy, I don't want to take no antidepressant. SSRIs have multiple different usages. Controlling your serotonin reuptake will help with hot flashes. Yes, it's an antidepressant, but it also can be utilized for hot flashes. That would be the first line medication to use before you use hormone replacement therapy to see if your hot flashes can be manageable. All right. They may not always go away completely. Right. So if you have an occasional hot flash, that's not truly a reason for you to start hormone replacement therapy. If you can get it to where it's manageable, go with that. Right. But if it's to the point where you've done all of those things, you've taken the SSRI, and you're still having daily horrible hot flashes, then it's hormone replacement therapy at that point. And you start off with the lowest dose of hormone replacement or estrogen replacement, and then you can titrate up as needed.
All right. This one is from the chat. and I know this is a quick one. How can you prepare yourself for a fibroid surgery as far as diet? Will anything help shrink them? I always hear going vegan will help.
Nope. So I operate on vegans, vegetarians, pescatarians, people that just stop eating meat, people that's been eating meat, people that, like, you name the diet, people that eat dairy, don't eat gluten, like, none of that stuff has been proven. And I have people all the time with that, and I let them say it. I don't interrupt them. They come in like, my fibroid was, it's been big, and I stopped eating meat, a year ago. That's good. Like, that's for your overall health. That's fine, but it's not shrinking your fibroid. There's nothing, from your diet perspective that's going to shrink them. You want to eat proper and have a good diet for your general health, your overall health. Damn the fibroids. This is for your general health, your life. Like, that's what it's important for. But no, there's not really a food that's linked to fibroids. I see patients of every diet that will have fibroids. So eat healthy, drink a lot of water to prepare for surgery. But it's not going to just necessarily shrink the fibroid.
Okay, this one looked like it's for me. How was it affecting your sex life? So when I say affecting my sex life, I would not have pain during sex, but I would have really, 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 really bad cramping after sex. And sometimes I would have random bleeding out of nowhere. And because my fibroids were large, sometimes when I spot, it's not a spot. It's more like a pool, bleed out. So it would happen randomly, bed sheets replaced, stuff like that. So I would have those issues going on. And it definitely, it also affects your partner, because they start, maybe at first it's the baby boy scene, they happy, like, I told you up, but then they start looking at you like, wait, am I hurting you? And then it's not as sensual anymore or whatever. So yeah, so it starts to become stressful for everybody, because it's painful afterward.
Somebody asked about UFEs too, or uterine fibroid embolization. I hate it. All right. If people ask me my opinion about UFEs all the time, I am not an advocate of uterine fibroid embolization. So questions asked like, have anybody that's had UFEs and have fibroids come? Absolutely. Most of my patients that have had UFEs do not have good outcomes. It's my experience. People will get mad about, what I'm saying and my opinion, but I give you my opinion from experience. It's not just because I don't like them. It's because I don't have good experiences with patients that have had them, right? And if you look at the physiology behind them, it's not good, honestly. And no offense to any of my interventional radiologists that perform them. No offense to my gynecologists that don't really have the skills to deal with fibroids and send them to interventional radiologists. No offense to none of y'all, but I am going to be honest with the people and let you know, like, do I offer UFEs to my patients? Yes, I do, because I don't believe that no matter what my opinion or my experience is, I should never take away your option. UFE is an option. You should have an option. I'm going to tell you why I don't think it's a good option. But at the end of the day, if that's what you want, go right ahead. But I don't agree with, I'm not a proponent. I won't say I don't agree with. I will say that I am not a proponent of uterine artery or uterine fibroid embolization. They are the same thing. They're synonymous.
Okay. Can fibroids die or degenerate? It's in the chat.
They can degenerate. You can have some degeneration of fibroids, of small fibroids, or even pedunculated fibroids. Pedunculated means the fibroids that kind of hang off of the uterus. If your fibroids are very large, the chances of that happening are very small. If you have estrogen, progesterone, meaning your reproductive age, typically not going to happen. They'll get bigger before any of that happens. It's just without doing something to it, without compromising the blood flow or the hormone levels, like, you're not going to cause it to die or degenerate. It's not something that's very common. Somebody asked. Answer this one real quick. Can you hear me?
Okay, I can hear you now. I didn't hear you for like.
Yeah, go ahead. Yeah, take over real quick. I got to answer this phone call.
Okay. Well, actually, I think we do have to get ready to end because we will get to that 1 hour timeline. So
okay, yeah, that's right.
Yeah, and Instagram starts acting funny if you go past 1 hour. But as I mentioned, we are trying to do them as long as people send stuff and want to know stuff. So we will try to make it monthly, regularly, as much as possible, or as long as they're needed. If there's a need for this, we will continue to do it. I'm okay if you submit stuff to me. You want to remain anonymous. I'm perfectly fine with that. I will be the advocate or the front runner. I will ask for you. So I really appreciate. Oh, I'm sorry.
And last, somebody asked if I'm in where am I located? I'm in Chicago. I take most insurances. Like you just have to call and like talk to my insurance people. I made a point to not cut people off for insurance. That's why I'm here. That's why I'm working. I'm not gonna do this forever. I got 3.5 years. I'll tell y'all right now, y'all better use me while I'm here. But as of right now, like I take all insurances. It really kind of just depends on the hospital, though. Just because I accept it doesn't necessarily mean the hospital does. So you have to kind of work with my team to see if they will accept it or not. But look me up, hit me up, DM me. Office number is 312-929-9191. You can always, call the office too if you're local. If you're not local, then just, reach out, to me, DM me. I do consults. I do, video consults and stuff too. So just let me know.
All right. Well, we appreciate you, doctor. And I hope you have a good rest of your year and see you in the new year.
All right.
All right.
See you later.
Take it easy.
Everybody, Happy New Year. See y'all later.
Bye-bye.